Rector magnífic de la Universitat Autònoma de Barcelona, presidenta del Consell Social, degà de la Facultat de Medicina, padrí de la doctoranda, deganes i degans, personal tècnic d'Administració i Serveis, alumnat i membres de la comunitat universitària. És un honor, com a secretària general d'aquesta universitat, llegir l'acte de nomenament com a doctora honoris causa de la senyora Ingrid Lundberg, reconeguda metgessa i investigadora del Karolinska Institutet. Els seus estudis s'han centrat en les miositis o miopaties inflamatòries. Entre les seves aportacions destaquen l'estudi genètic d'aquestes malalties i l'esforç internacional per fixar uns criteris classificatoris homogenis i útils. Sens dubte, els seus treballs han esdevingut referències indispensables en el camp de la medicina. A continuació, llegeixo l'acord adoptat pel Consell de Govern. Acord 44/2024 de 24 d'abril del Consell de Govern. Vista la petició formulada pel deganat de la Facultat de Medicina i l'acord de la Junta Permanent de la Facultat de data 12 de desembre de 2023, pel qual se sol·licita al Consell de Govern el nomenament de la senyora Ingrid Lundberg com a doctora honoris causa de la Universitat Autònoma de Barcelona. Atès que tant del currículum de la candidata com de la documentació referent als seus mèrits i de les circumstàncies que concorren, queda acreditat que la seva activitat en el camp de la docència i de la recerca la fan mereixedora d'obtenir la distinció de doctora honoris causa de la Universitat Autònoma de Barcelona. Atès que la normativa que regula el procediment per a l'atorgament del títol de doctora honoris causa aprovada pel Consell de Govern en data 26 de maig de 2004, en el seu article 5.2 estableix tota una sèrie de pressupòsits i requisits a considerar pel Consell de Govern per poder atorgar aquesta màxima distinció i incorporar a la candidata a la nostra comunitat. Atès que la proposta de la Facultat de Medicina compleix amb escreix els requisits exigits a la normativa abans esmentada. Per tot això, a la vista de les consideracions anteriors, a proposta de la Junta Permanent de la Facultat de Medicina, el Consell de Govern adopta l'acord de nomenar a la senyora Ingrid Lundberg, doctora honoris causa de la UAB, a Bellaterra, 24 d'abril de l'any 2024.
Rector magnífic de la Universitat Autònoma de Barcelona, degà de la Facultat de Medicina, presidenta del Consell Social, autoritats acadèmiques, membres de la comunitat universitària, metges i metgesses, senyores i senyors. És per mi un privilegi i un honor presentar davant de la comunitat universitària a la professora Ingrid Lundberg, nominada com a doctora honoris causa per la nostra facultat a petició del Departament de Medicina. No faré aquí un recull exhaustiu dels seus mèrits o del seu currículum vitae, que d'altra banda ja estan recollits al llibret de l'acte d'investidura que trobareu a la web de la nostra universitat. Faré, en canvi, una laudatio dels aspectes més rellevants des del punt de vista acadèmic i humà d'aquesta professora. Vaig conèixer Ingrid Lundberg durant una reunió científica que va tenir lloc a Estocolm, a Suècia, concretament a l'Institut Karolinska, l'any 2004, fa més de 20 anys. El lloc on se celebrava l'esdeveniment era la seu on es lliuren els Premis Nobel, un marc, doncs, incomparable. Ja aleshores em va cridar l'atenció la manera d'expressar el seu coneixement sobre aquestes malalties tan complexes i rares, les miositis, i la facilitat de relacionar-se i comunicar-se amb altres metges clínics, però també amb científics d'altres especialitats i investigadors bàsics. El títol de la reunió interaccions entre el sistema immunitari i el metabolisme muscular, per què es debiliten els músculs en malalts amb malalties musculars inflamatòries cròniques, ja era indicatiu de la seva curiositat i inquietud per la malaltia i del seu compromís per intentar ajudar els malalts que la pateixen. Al llarg de tots aquests anys, la professora Lundberg ha estat clau en el lideratge de projectes rellevants que han canviat i modificat el coneixement mèdic i científic sobre aquestes malalties, entre els quals cal assenyalar la classificació de les miopaties inflamatòries de l'any 2017, actualment en revisió en un projecte liderat per ella mateixa, el Registre Europeu de Miocitis o el recent projecte sobre la història natural de les malalties musculars inflamatòries. La professora Lundberg ha publicat nombrosos estudis en revistes d'alt impacte i ha participat en conferències, simpòsiums i congressos per tot el món. Una de les capacitats de la professora Lundberg és la d'aglutinar metges clínics i investigadors d'arreu del món i engrescar-los en projectes que tenen repercussió en la pràctica clínica. L'any 2015 es va celebrar el primer congrés mundial dedicat a l'estudi de les miopaties inflamatòries, a Global Conference on Myositis. Va ser precisament la professora Lundberg la impulsora d'aquestes reunions, que s'han anat celebrant cada 2 anys i que únicament van estar interrompudes per la pandèmia del Covid-19, que tantes coses va interrompre. L'última reunió va tenir lloc l'any 2024 a Pittsburgh, als Estats Units, i la professora Lundberg va tenir també un paper molt rellevant. El seu lideratge a l'Institut Karolinska, on desenvolupa la seva activitat assistencial, docent, investigadora, actua com un pol d'atracció per a metges i metgesses d'arreu d'Europa, Àsia o els Estats Units, que hi acudeixen no només per formar-se en l'estudi d'aquestes malalties, sinó també per participar en la recerca capdavantera que desenvolupa. Metges i metgesses formats a la Universitat Autònoma de Barcelona han tingut l'oportunitat de gaudir d'aquesta experiència. La doctora Anne Lavirua, avui també present en aquest acte acadèmic, que va llegir la seva tesi doctoral sobre la síndrome antisintetasa i de qui em consta que la professora Lundberg guarda un record molt bo, va estar a l'Institut Karolinska l'any 2010. També els doctors Ernesto Trallero i Lluís Jubany van gaudir de l'experiència de participar l'any 2011 a l'Escola d'Estiu sobre Miocitis que cada any organitzava la professora Lundberg. Més recentment, la doctora Irene Peralta, reumatòloga formada a la unitat docent Germans Trias i Pujol, i uns mesos després d'una estada a l'Institut Karolinska ha passat a formar part de l'equip de la professora Lundberg com a responsable de l'estudi sobre la història natural d'aquestes malalties, les miocitis. Tot això ha contribuït indubtablement a enfortir els llaços entre ambdues institucions. Aquesta generositat en acceptar metges i metgesses joves al seu centre és una característica de la professora Lundberg que l'honora. El compromís amb l'ensenyança i la formació ha estat palès durant tots aquests anys en incorporar l'estudi de les miocitis a diversos grups d'associacions mèdiques, com ara l'Aliança Europea d'Associacions de Reumatologia, EULAR, o la Xarxa Europea de Malalties Rares i Complexes del Teixit Connectiu i Musculoesquelètic, RECONET, on participar en el Centre Neuromuscular Europeu en l'estudi de la qualitat de vida relacionada amb la salut, entre d'altres temes d'interès. Hem de recordar que aquestes malalties, les miopaties inflamatòries idiopàtiques, han estat durant molts anys, degut a la seva raresa i a la seva dificultat en el tractament i la cura, malalties oblidades, la qual cosa ha comportat un important sofriment als malalts que les pateixen. Per tot això, el paper de la professora Lundberg és tan important, ja que contribueix no solament al diagnòstic i tractament d'aquests trastorns, sinó també a la seva visibilització. N'hem ressaltat fins ara la capacitat de lideratge, el coneixement científic i la vàlua com a professional mèdica, però seria injust no ressaltar-ne aspectes més humans, com ara la seva relació amb els malalts i les associacions de malalts, la seva generositat i el respecte als seus col·legues i professionals de la salut i, per descomptat, també als metges joves en període de formació. El seu sentit de l'humor, la seva bonomia i una desconeguda per molts habilitat pel ball i la interacció social fora de les estructures acadèmiques són aspectes que també voldria destacar i que contribueixen a ressaltar encara més l'extraordinària persona que és la professora Lundberg. It's a privilege and an honor to introduce to the university community Professor Ingrid Lundberg, nominated by our faculty for an honorary doctorate upon the recommendation of the Department of Medicine. I will not provide you with an exhaustive list of the merits or curriculum vitae of Professor Lundberg, which are already included in the booklet for this event, which is available on the UAB website. Instead, I would like to refer you a laudation of Professor Lundberg's most significant achievements from both an academic and human perspective. I met Professor Ingrid Lundberg during a scientific meeting held at the Karolinska Institute in Stockholm, in Sweden, in 2004, more than 2 decades ago. The event took place at the prestigious venue where the Nobel Prizes are awarded, providing an exceptional academic setting. Even then, I was deeply impressed by Professor Lundberg's ability to articulate her knowledge of the rare, challenging group of diseases known as myositis, and her talent for engaging in meaningful dialogue with clinicians and professionals from other specialties, including basic research. The meeting's topic, interactions between the immune system and muscle metabolism, why do muscles weaken in patients with chronic inflammatory muscle diseases, reflected her scientific curiosity and concern about these conditions and her commitment to helping the affected patients. Over the years, Professor Lundberg has played a key role in leading projects to advance the medical and scientific knowledge related to these diseases. Among the most notable is the 2017 classification of inflammatory myopathies, which is currently undergoing an update in a project led by her, and the Euromyositis Registry. A more recent initiative is focused on the natural history of inflammatory muscle diseases. She has published numerous studies in high-impact journals and participated in conferences, symposia, and congresses worldwide. One of Professor Lundberg's great abilities is bringing together clinicians and researchers from around the world, inspiring them to engage in projects that have a direct impact on clinical practice. In 2015, the first ever global conference on myositis was held, dedicated to the study of inflammatory myopathies. Professor Lundberg has spearheaded this meeting, which have since taken place every 2 years, interrupted only by the COVID pandemic. At the most recent conference, held in 2024 in Pittsburgh, USA, Professor Lundberg once again played a highly significant role. Professor Lundberg's leadership at the Karolinska Institute, when she carries out her clinical, teaching, and research activities, serves as a major attraction for physicians from Europe, Asia, and the United States. These professionals are drawn by the opportunity to receive a specialized training in the study of these diseases and to actively participate in the cutting-edge research conducted under her guidance. Several physicians trained at our institution, the Universitat Autònoma de Barcelona, have benefited from this experience. Dr. Anne Labirua, who is present at today's event and held in fond regard by Professor Lundberg, defended her doctoral thesis on antisynthetase syndrome and spent time at the Karolinska Institute in 2010. Dr. Ernesto Trallero and Dr. Lluís Jubany participated in the Myositis Summer School in 2011, an annual program organized by Professor Lundberg. More recently, Dr. Irene Peralta, a rheumatologist trained at the Germans Trias i Pujol Teaching Unit, completed a research stay at the Karolinska Institute and has since joined Professor Lundberg's team, where she is now in charge of an international study on the natural history of myositis. This activity has undoubtedly strengthened the ties between our two institutions. Welcoming young doctors to her center is a great mark of Professor Lundberg's generosity. Her commitment to education and training has been increasingly evident over the years through the integration of myositis research into various medical associations and networks, such as the European Alliance of Associations for Rheumatology, the EULAR, and the European Reference Network on Connective Tissue Disorders, the RECONNET, as well as participation in research groups such as the European Neuromuscular Centre, focusing on health-related quality of life, among other issues. It's important to acknowledge that idiopathic inflammatory myopathies have historically been neglected due to their rarity and the challenges they present for treatment and management. This lack of attention has been detrimental for the individuals affected, and it is why Professor Lumber's contributions are so important, as her work extends beyond the diagnosis and treatment of these diseases to include efforts aimed at increasing their visibility within the medical community and beyond. So far, we have highlighted Professor Lumber's leadership skills, her scientific knowledge, and her excellence as a medical professional. However, we cannot overlook her human qualities. Her relationship with patients and patient associations, her generosity and the respect she shows toward colleagues, health professionals, and young doctors in training, her sense of humor, warmth, her social interaction beyond academic settings, as well as a little-known talent for dancing, further highlight the extraordinary person she is. For all these reasons, it is my pleasure, honor, and privilege to request of the Honorable Rector of the University Autónoma de Barcelona that he confer the degree of Honorary Doctor on Professor Lumber. És per això que tinc el plaer i l'honor i el privilegi de demanar al rector magnífic de la Universitat Autònoma de Barcelona que s'atorgui el grau de doctor honoris causa a la professora Ingrid Lumber. Moltes gràcies.
Sí. Heu estat designada doctora honoris causa pel Consell de Govern de la Universitat Autònoma de Barcelona i com a símbol us lliuraré un diploma i la medalla d'honor, la medalla de doctor honoris causa. Us admeto i us incorporo al claustre de professorat de la Universitat Autònoma de Barcelona. Dono la paraula a la doctora Ingrid Lumber, que farà el seu discurs d'incorporació a la comunitat acadèmica. Quan vulgui.
So good afternoon. First of all, I would like to express my sincere gratitude to Universitat Autónoma de Barcelona for selecting me to become honorary doctor at your university. I'm truly honored. So in my clinical and academic career, I've focused to understand more about the disease we heard Dr. Selva mention several times, rheumatic disease called myositis. And today, I will present some of the achievements we have reached over the 30 years that I have worked with this disease. So these are my disclosures, and today I want to give you a little update on first the background on when I started the disease, how we looked at it, and then what has developed over the times, new subgroups that have been identified, and also somehow we have worked together in the international community. So when I started to work in rheumatology, we learned that the inflammatory myopathies, or myositis, is a chronic disease and is characterized by weakness of muscles and low muscle endurance. And typically you see the inflammation in the muscle tissue. And the diagnosis of this disease is based on the objective clinical muscle weakness, and this is mainly affecting arms and legs, and particularly proximal muscles and like the neck flexors, and this with a symmetrical distribution. But in addition to the clinical manifestations, you need to find signs of a myopathy, and one way is to see elevated muscle enzymes in serum, like CK. Another is to use EMG with a myopathy pattern, and most importantly, to find inflammation and changes in muscle fibers in muscle biopsies. And in some patients, we have the skin rash that you can see here to the right, which is then defined the subgroup of dermatomyositis. Now today, we also have access to MRI to detect edema in the skeletal muscle, which is an indication of inflammation, and we have autoantibodies that are found in myositis. But then when I started, we had it is a complex disease that was known for a long time, and we had the subgroups that had been identified based on differences in clinical and histopathological features in the muscle tissue. And we could then subgroup patients into polymyositis, dermatomyositis, inclusion body myositis. We have also in children the juvenile onset dermatomyositis and cancer-associated myositis. Now this is a rare disease with an incidence of approximately 11 per 1 million person years, and is a chronic disease with a prevalence of approximately 14 per 100,000. It's slightly more common in women than in men, and all ages may be affected, including children. But the peak years of incidence for both men and women is between 50 and 79 years. So this is a difficult to treat disorder, often with severe symptoms, and treatment is based on immunosuppressive treatment, high doses of glucocorticoids, often in combination with methotrexate or even now biologics like rituximab. But even with this very aggressive treatment, few patients recover, and most patients have persisting weakness, and the muscles are easily fatigued and lead to a low quality of life. These patients also have an increase of early deaths with a high mortality. So when I started as a young doctor, we recommended the patients pharmacological treatment, mainly glucocorticoids, and rest. And there was a very slow recovery. So how can we improve outcome in patients with this disease? And here I think it's important that we learn from our patients. So we, in the textbook, we had the recommendations that with this disease, you should have the treatment with glucocorticoids and rest. So that's what we told the patients. One day in my clinical office, a 50-year-old man with newly diagnosed polymyositis, he had been very weak, could hardly move, but we had started treatment with glucocorticoids, and he went back home. And he came back to my office after around 6 weeks, and he was very happy, and he lay down on the floor of the office and showed me how many push-ups he could do. And of course, he had been disobedient to my advice to rest, and I asked him, how did you accomplish this? Well, I started to train with my daughters who are elite swimmers, and I realized I improved in my muscles. So then I went back to the literature to see what was the reference or the recommendations of rest were based on. And then I realized that these recommendations were based on studies by sports physiologists that had taken muscle biopsies from healthy individuals after running marathon. And when you look into the muscle with a microscope after a marathon race, you can imagine there's a lot of inflammation and necrotic fibers. So then the interpretation was that if exercise leads to inflammation and you already have an inflammation, it would not be good to exercise. But of course, marathon is not the type of exercise level we would recommend our patients. So this was my introduction into research on myositis. So I started a collaboration with our physical therapist, and we asked ourselves, can patients with myositis tolerate exercise, and can they benefit from exercise? So over the years, I worked closely with Helene Alexandersson, physical therapist and now associate professor. But at that time, there were no studies on exercise in myositis. So we designed a very careful program introducing exercise to patients that were in a stable phase of the disease. They had been treated for at least a year. They had no signs of active inflammation in their muscles. And we designed this 12-week home exercise program. And we measured the muscle strength before and after the 12 weeks. But in addition, we took a muscle biopsy before and after the 12-week program to see if there would be an increased inflammation. And this is Helene Alexandersson demonstrating the type of exercise, different muscle groups. And this was only 15 minutes. And to avoid overuse of the muscles, we shifted between the muscle groups. And this was the 15-minute exercise program was followed by a 15-minute walk, 5 days a week. And what happened? Well, we could measure the improvement in muscle strength and function with the functional index, you see to the left, with a maximum score 64, so some patients reached this. And to the right you have the physical function, which is a questionnaire, so patients improved in both. And importantly, there were no signs of increased inflammation in the biopsies or according to the levels of muscle enzymes. So then we were encouraged by these results, and as the patients improved, we asked ourselves if there is a molecular explanation to the improved performance. And to answer this question, we designed a controlled trial with patients with myositis that were randomized to either exercise group or a control group. And now we used more intensive exercise. So they had this exercise on a bike with 70% of their VO2 max, followed by 20-minute muscle endurance in different muscle groups. And this was done 3 times a week for 12 weeks. And the control group, they were advised to just continue with their level of activity they had. And these were again patients with a stable disease. They were on treatment with immunosuppressive therapies, but had not improved to their performance before they became sick. And this is just a summary of the results. So actually the patients in the exercise group, they could cycle for a longer time. They improved their fitness with the maximum VO2 max. And which was a surprise to us, there was also an improvement in disease activity measured in different ways, whereas the control group didn't change at all. And then we investigated the muscle biopsies that we took before and after, and this is just a summary of the gene expression data, where we actually saw a beneficial effect on capillary growth, mitochondrial biogenesis, protein synthesis, cytoskeletal remodeling, and muscle hypertrophy, meaning that the exercise induced growth of the muscle fibers. And in addition, there was a downregulation of genes involved in inflammation. So now today, we can conclude from our and other studies that physical exercise for patients with myositis is safe and it's effective to improve strength and fitness, just as in healthy individuals. And importantly, it seems to be able to counteract inflammation, so it should be a complement to the pharmacological therapy, and that's now written in the textbooks. So these studies we started with in patients that were subgrouped into poly and dermatomyositis, but over the past 20 years, new subtypes of myositis have been identified. And this is thanks to the discovery of several autoantibodies that have been identified to be specific for patients with myositis. These have been discovered by many investigators all around the world. So we now have one group of autoantibodies that are targeting tRNA synthetases that you see in the middle, and patients with these autoantibodies, often in addition to the before the dermatomyositis, with the skin rash, there are now 5 different autoantibodies. And then we have the group of myositis with the SRP, HMDCR antibody that are associated with a severe myopathy. We also have antibodies in myositis patients that can be identified in other diseases, and they are called myositis-associated autoantibodies like the PMSCL and RO52, and I will come back to them. But they can also be found in patients with lupus and Sjögren's syndrome or systemic sclerosis. So now, based on these autoantibodies, we can add subgroups like the antisynthetase syndrome, the immune-mediated necrotizing myopathies. Also, we can identify patients with dermatomyositis without muscle weakness, and they are called clinically amyopathic dermatomyositis. And still, we have a group that are seronegative that we should not forget. And moreover, we have learned that myositis is not only a muscle disease. And even if we knew the skin rash was common, we now know that many patients have involvement of the lung with interstitial lung disease. Many patients have arthritis, and some patients may even have involvement of the heart muscle with myocarditis. So I will now focus a bit more on the patients with lung disease and myositis. So over the years, we have identified that in the subgroups dermatomyositis and polymyositis, up to 70% may have signs of interstitial lung disease, not always clinically affecting patients. And in this patients with the antisynthetase syndrome, up to 90% may have interstitial lung disease. And moreover, the interstitial lung disease may be the first symptom, it may be the predominating manifestation, and it's a major cause of morbidity and mortality. And these patients may come to the emergency room, often come to the lung disease doctors to start with. And in particular, there are 2 autoantibodies that are the most frequent, the anti-Jo1 of the antisynthetase and the anti-MD5, one of the dermatomyositis antibodies that are strongly associated with interstitial lung disease. So why the lung? And to answer this question, we used Swedish hospital registers, national registers, to identify epidemiological risk factors to develop myositis. And through this research, we identified both infections and respiratory tract disease as risk factors for myositis. And here I want to show you what we did. So we used the national registers for hospitalization and outpatient visits, and we identified both infections and respiratory tract disease as risk factors. And what we did, we took patients with myositis here, and you see almost 1,000, and then we had controls from the register, almost 10,000. And then we could compare the risk for having been hospitalized or being in the outpatient clinic with infections. And here we can see that in particular the lung infection is a risk factor to develop myositis. And moreover, not only respiratory tract infections, but other respiratory diseases were also risk factors. So that means that patients that have a diagnosis of myositis more often had been hospitalized or been to a outpatient clinic because of infections, and particularly respiratory tract infections, or been hospitalized with a respiratory disease. And the respiratory disease is both upper and lower respiratory tract. It could be sarcoidosis, but also chronic obstructive lung disease or asthma. And it was not only this, there was also a dose effect. So the more often you had been hospitalized or been at the clinic with here you can say one or more visits, or for the respiratory disease, there was a higher risk of developing myositis if you had had these diseases. So that means that there is an epidemiological evidence of the lungs being involved before you have the myositis. So then we have focused to understand more of the antigen-1 positive disease, because that's the largest group of the subgroups of the myositis. So what do we know about risk factor for this subgroup? So here we investigated the role of smoking and HLA DRB103 genotype to develop myositis. So this is a study in patients with myositis, and it's a collaboration between Hungary, Czech Republic, UK, and Sweden. And first we can see the antigen-1 was present in approximately 20% of patients with myositis. And it's also a bit astonishing, I think, this was some years back, but smoking ever was very high, over 50% in Sweden and UK. So then we were interested if there could be an association between the HLA-DRB103 genotype, which was reported to be one of the most common genetic association with myositis. And here we used smoking ever or and DRB1. So our reference group is the first one, never smokers and non-DRB103. And in that subgroup, 8% were antigen-1 positive. So that was the reference group. But if you had DRB103 without smoking, 31% were DRB1 positive. And if you were a smoker, DRB1 negative, 11%. But if you were both a smoker and had the HLA DRB103, 42% had the Jo1 antibody. So this smoking and HLA type may be to interact, to increase the risk of having this Jo1 autoantibody. So then, could it be that the disease could actually be initiated in the lungs? So this antigen, the histidine-tRNA synthetase, is an enzyme that's expressed in all cells, but some other groups from Johns Hopkins had shown that there was a higher expression of this enzyme in cells in the lungs, and also in cells that are muscle cells that are going regeneration, like after damage. So there is some tissue variation in the level of the expression of this enzyme. Moreover, Dr. Levine, also at Hopkins at that time, he showed that granzyme B, which can be induced by infection, like in the respiratory tract, can cleave the enzyme and then expose new epitopes that could be recognized by the immune system. And also that the enzyme, HISRS, can act as a chemokine, attracting cells into the lung tissue. So to understand this immunity reaction more, we asked if there are T cells that are reacted to this HISRS protein in patients with anti-Jo1 antibodies. And this was a work that Dr. Angeles Galindo did as part of her PhD. And what we did here, we took peripheral blood from patients with myositis and antisynthetase syndrome. And we stimulated the peripheral blood cells with the protein and also with the peptide that was recognized to fit into this HLA-DRB103 that was identified through a collaboration with Benaroya Institute in Seattle. So we used as a reference, this is one patient that we have on all these plots, and up here we have the unstimulated cells. And then we measured the reactivity by T cell activation marker, which is called CD40 ligand here, and production of cytokines, interferon gamma, IL-2, and IL-17. And when we compare the level of activity and cytokine production in the upper level with when we stimulated the cells with the full-length protein and then with the peptide, you can see there is a much higher production, the activation of T cells, but also here particularly of the IL-2 and interferon gamma compared to the unstimulated cells. Now these are cells from peripheral blood, but in collaboration with the lung doctors, we also had access to cells from the bronchoalveolar lavage from myositis patients with anti-Jo1 antibodies. And it's the same setup with unstimulated cells, cells stimulated by the full-length protein and with the peptide. And here you can see the activation of T cells is even much higher in cells from the lung compartment. Here 75% are activated by the peptide to produce interferon gamma. And that's summarized in this little graph here. So the cells coming from the lung compartment are much more easily activated by the peptide from the Jo1 protein. And in addition, we analyzed the bronchoalveolar lavage fluid for antibodies, the anti-Jo1 antibodies. And we compared the levels in the BAL fluid with the serum, as you can see here, to the BAL fluid, and we compared to individuals with sarcoidosis or healthy individuals. And you can see there is almost higher levels, at least it was significantly higher levels of the anti-Jo1 in the BAL fluid compared to the serum. And then we also had the possibility to investigate lung biopsies taken from patients with anti-Jo1 antibodies and also from control individuals. And in the patients with anti-Jo1 antibodies, but not in the others, we found these germinal center-like structures in the lung tissue, with the T cells and plasma cells, so indicating that there actually could be a production of autoantibodies in the lungs of these patients. So our hypothesis now is that the lung could be a site of triggering the immune reaction towards the His-RS protein, and possibly with anti-Jo1 antibody production. And this may later result in an autoimmune disease in the lungs and the muscles, but we still have some steps to prove this. So lung and the infection in lung is one risk factor to develop myositis, but it's also since 100 years known that there is an increased risk of cancer in patients with myositis. So to address this, we again use the Swedish population register, the healthcare registers, and the cancer registers. And we identify patients with IAM, with myositis, and compare to controls from the population. And first we asked if there is a cancer risk before you have a diagnosis of myositis. And indeed we found that overall risk of cancer in patients with myositis, here the patients with myositis, here the controls from the population. So it's 1.5 times or 50% risk. As you can see, it's a higher risk of having cancer before myositis diagnosis. And this was in particular for the subgroup. Here we could only subgroup the patients according to juvenile onset, dermatomyositis, and adenomyositis. And it was in particular for the adult patients with dermatomyositis a higher risk to have cancer before myositis diagnosis. And then we also investigated if there is a risk of having cancer after the myositis diagnosis using the same registers, and indeed you can see there is a higher risk of cancer also after the diagnosis. And what was even more interesting was that the cancer type, the site-specific cancer, was different in patients having cancer before and cancer after myositis diagnosis. So in the cancer site before diagnosis of myositis, there was in particular lung cancer, colon cancer, and urinary tract cancer, and also breast cancer. But after having the diagnosis of myositis, is particularly higher risk of having oral cancer, pharyngeal cancer, female genital tract, and that's in particular ovarian cancer. But skin and hematopoietic cancers were both before and after myositis diagnosis. So for a long time, we haven't had any biomarker to identify patients with myositis and dermatomyositis with a higher risk of malignancy. But over the years, or recent years, 2 autoantibodies have been identified to be strongly associated with cancer, and that's the TIF1, which is the most common, and NXP2 antibodies. And the anti-TIF1 gamma autoantibodies constitute a risk of having cancer, and this is specific for patients with dermatomyositis. And in adult patients, 50% have a risk of developing cancer. And if you are above the age of 40, it's a high risk as 75% to develop cancer. So this is one of the collaborations we did with the group of Dr. Selva. And here we have the 2 cohorts, one from Karolinska and one from Barcelona. And we investigated the time interval in years between myositis diagnosis and cancer diagnosis in patients with and without anti-TIF1 gamma antibodies. And the black bars are the TIF1 gamma positive, and the 0 is the time of myositis diagnosis, and it's very similar that if you have the antibody, it's a very high risk to have the cancer very close to myositis diagnosis before or after. But it was also identified that you can have the antibodies for many years before you have the myositis diagnosis. And we can also identify that, or the clinical consequence of this now in the international recommendations is that patients with anti-TIF1 gamma antibodies should be screened for cancer not only at the time of dermatomyositis or myositis diagnosis, but also annually up to 3 years after the diagnosis of myositis if you have the TIF1 gamma antibodies. So then we have asked, is there a role of the autoantibodies in the pathophysiology with these distinct clinical phenotypes? So one approach we took here was to use the large cohort that we had in collaboration with UK, Czech Republic, Denmark, Norway, and Sweden, with almost 1,500 patients. And we used these modern unsupervised clusters, and by using that we identified 8 groups, subgroups of myositis based on autoantibodies. And what you can see here, as to the left, we have the seronegative, then we have one column with anti-TIF1 gamma, and they don't have any other autoantibodies, so it's very monospecific. Which was interesting was that patients with anti-Jo1 antibodies, one of the most common, we identified 2 groups, one with only anti-Jo1 and one with here, RAW52 and Jo1, and then some other more heterogeneous groups. But then we were interested if the antibody type was associated with any specific HLA association. And I've already mentioned it was well known that patients with antigen 1 had an association with the DRB103 that we can see over here. But it was interesting that if you have antigen 1 and Rho52 antibodies, which is often associated with more severe disease, they have also some other associations. And we could confirm the TIF1 gamma association with another DRB1, and also with antigen 1 and RMP and PMSCL, we identified specific HLA associations. And to the left are the subgroups based on autoantibodies, and to the right based on clinical diagnosis. And if you look, for instance, at the dermatomyositis, if you follow the lines here, you can see that patients with dermatomyositis with the clinical definition have a much larger variability in the HLA associations, whereas the subgroups based on autoantibodies is a much smaller. So the antibody-defined subgroups have a much higher, is more restrictive HLA association. So the interpretation of this, now we can summarize that the HLA class 2 and to some extent HLA class 1 association were observed for almost all autoantibody-defined subgroups. And the role of the HLA genes is to encode class 2 and class 1 antigen presenting molecules that has a primary function to present peptides to T cells. And these T cells can then initiate the antigen-specific adaptive immune response that may result in the production of autoantibodies. So these results support to use the autoantibody-based subgroups for classifying patients and also for further studies of the pathophysiology. But as I started, the myositis typically have involvement of the muscles, but these autoantibodies don't really explain why the muscles are the target of the immune reaction, because all the antigens I've talked about so far are expressed in all cells. So this was the background why we did this project, where we used muscle cDNA library and screened this with sera from myositis patients. And here the protein FHL1 caught our interest. And we also have the histidine-tRNA synthetase here as a positive controls. But this FHL1 is a protein that's highly expressed in skeletal and cardiac muscle and plays an important role in muscle growth. And there have been several diseases reported due to mutations in the FHL genes, like the severe muscle dystrophies that you see here. So we developed an assay to screen for anti-FHL1 autoantibodies and found them in 25% of patients with myositis, but rarely in other subgroups, other autoimmune diseases, or in genetic muscle disorders. And then we asked ourselves, is this just a consequence of muscle degeneration? So Angeles Galindo did this work where she analyzed longitudinally collected patient sera that you see up here. And what we identified then was that the first serum, the levels of antibodies that you have on the y-axis were highest at the time of myositis diagnosis, and then with time, they dropped. And if the patients were seronegative in the first sample, they rarely developed anti-FHL1 antibodies. And moreover, the levels of the anti-FHL antibody were associated with muscle involvement, both the MMT8, which is a muscle strength test, with the inverse correlation with the CK level from the serum, and the disease activity measure of myositis. So to the panel of autoantibodies, we can now add the anti-FHL1 antibody. And to work with this rare disease is evident that we need to collaborate. So together with Dr. Hector Chinoy in Manchester and Dr. Jiří Venkovský in Prague, we developed an international web-based register to collect data from myositis patients in 2008, and now we have more than 6,700 patients in this, from 30 centers in this register. And this register was developed both to use in clinical practice to support decision making of treatment, and this is what it looks like. So here we have this is from one patient, and each of the columns marks a visit. And we can here see the patient activity recording from 50 to 23, and below physician activity recording and the muscle strength. So we have the disease activity, and we have damage, and we can also include treatment. So this is helpful in the clinic to discuss with the patients how they are doing and to adjust the treatment. But it can also be used for research. Like Dr. Fabrizio Espinosa did in his thesis, he used the data from the register from 14 centers, almost 800 patients. And he was interested if certain of the autoantibodies could predict risk of damage. And for damage here, we use the myositis damage index, MDI. And on the y-axis, you had the score of the damage index, and on the x-axis, you had the time of follow-up. And here we have used the subgrouping of patients with dermatomyositis autoantibodies, the antisynthetase that I've already presented. We have the seronegative as the reference group. And the red dots are women, and the blue dots are men. And the line is the trajectory of damage risk. And here, as you can see, the line, in particular for patients with PMSCL antibody, was at the highest risk of developing chronic, severe disease with a high level of damage. This was a bit surprise to us, and we don't know actually which risk factors there are for these patients. So that's a new project we have started to understand this more. So this is one way illustrating that we need a large number of patients from many centers. So what we can conclude now is that over the years, we have seen an evolving spectrum of myositis disorders, and antibodies have helped us to identify clinically more homogeneous phenotypes. And we have also learned that lung manifestations are common and can be the major clinical manifestation and might be a site of immune activation, but we need to learn that more. Antibodies can help us in the diagnosis, but also to make prognosis and treatment decisions. And we know it's important that if we work with myositis disease, we need international and interdisciplinary collaboration, because these patients could be seen by rheumatologists, internal medicine doctors, neurologists, dermatologists, and we really need to combine our efforts. And it's still important that physical exercise is an part of the standard treatment. And finally, I would like to acknowledge collaborators over the years. And, we can't sail without wind, and we cannot do research without collaborations. So I would like to acknowledge former and present PhD students, postdocs in our research group at Karolinska, and particularly Helene Alexandersson, that was brave enough to start with me the exercise studies. And also the collaborators both at Karolinska, the lung clinic, the immunologists, but internationally I've appreciate the work with Dr. Marianne de Visser in Amsterdam, Dr. Selva here in Barcelona for 20 years. I think that has helped us to learn more about this disease, not only for our patients, but for patients worldwide. And also finally, Dr. Chinoy, Venkovský, and Dr. Gordon, we started the Myonette register. So thank you so much.
Ara és el moment de l'actuació musical. Tenim el plaer de tenir aquí el cor de cambra de la UAB, dirigit per el Poere Ballbé. Quan vulgueu.
Come gather round, people, whatever you roam, and admit that the waters around you have grown, and accept it that soon you'll be drenched to the bone. If your time to start swimming or you sink like a stone, for the times they are changing.
Moltes gràcies. És un plaer sempre escoltar el cor de l'Autònoma. Professora Ingrid Lumber, nova doctora de la Universitat Autònoma de Barcelona, degà de la Facultat de Medicina, secretària general, vicerrectores, vicerrectors, padrí de la doctora Lumber, doctor Selva, autoritats acadèmiques, professores, professors, membres del personal tècnic de gestió d'administració i serveis, estudiants, amigues i amics. Avui, a proposta de la Facultat de Medicina, hem investit la professora Ingrid Lambert com a doctora honoris causa de la Universitat Autònoma de Barcelona per la seva contribució científica i el seu compromís acadèmic en el camp de les malalties autoimmunes sistèmiques i molt especialment de les miopaties inflamatòries idiopàtiques. El doctor Selva ha glossat magníficament la rellevància dels motius que justifiquen el nomenament de la doctora Lumber, però sobretot ens ha transmès de manera brillant els trets principals de la trajectòria acadèmica de la nostra nova doctora. coneixement científic, compromís amb els malalts, capacitat d'impulsar i liderar grans projectes, implicació en la docència i en la formació d'investigadors i especialistes. Són algunes de les qualitats que es desprenen de les paraules del padrí. Unes qualitats que, com el doctor Selva ha destacat, van acompanyades d'uns valors humans basats en l'empatia, la generositat i l'altruisme cap als malalts, els col·legues i els joves metges investigadors en formació. Sens dubte, els valors humans són essencials per avançar en el coneixement i en el progrés de la societat, perquè situen el benestar de l'ésser humà en el centre de les nostres preocupacions. La mateixa doctora Lundberg ens explicava a l'inici d'una lliçó excel·lent com el seu interès per la miositis va néixer del tractament amb els malalts i de l'observació del benefici de l'exercici físic en la simptomatologia de la malaltia. A partir d'aquell moment, l'aportació de la doctora Lundberg ha estat essencial per millorar la comprensió d'aquesta malaltia i el seu tractament. Estic segur que la sensibilitat i els valors de la doctora Lundberg són els pilars del seu talent investigador i mèdic i han estat essencials en l'impacte de la seva aportació. Un impacte que, més enllà dels avanços de gran rellevància en l'àmbit mèdic, ha estat cabdal per sumar esforços, crear xarxes i impulsar projectes de gran abast. És evident que la recerca col·laborativa i entre disciplines és fonamental per assolir fites rellevants en la tasca investigadora. En l'àmbit de les ciències de la salut, la cooperació és fonamental per avançar en el coneixement i en el desenvolupament de nous tractaments, especialment en el cas de les malalties poc freqüents. En aquest sentit, la contribució de la doctora Lundberg a la xarxa europea MIONET i a l'impuls de projectes i reunions científiques de caràcter internacional han estat cabdals per avançar en l'objectiu de millorar la divulgació, la comprensió, el diagnòstic i el tractament de les miopaties inflamatòries. A la UAB som molt conseqüents en que la interdisciplinarietat és indispensable per afrontar reptes de gran complexitat. Si volem avançar cap a una ciència més inclusiva, sostenible i col·laborativa, oberta a la ciutadania i en benefici de la societat, cal impulsar el diàleg entre disciplines per analitzar els fenòmens en tota la seva globalitat i aportar-hi solucions holístiques. D'altra banda, aquest afany de la doctora Lundberg per impulsar enfocaments col·laboratius i cooperatius en la recerca també s'ha traduït en un compromís de contribuir a la formació de metges i investigadors novells, una labor de la qual se n'han beneficiat moltes institucions d'arreu del món, entre les quals la UAB. En el cas de la nostra universitat, com molt bé ens ha recordat el doctor Selva, la relació fructífera del Departament de Medicina amb l'Institut Karolinska ha propiciat treballs conjunts i estades de recerca d'investigadors de la UAB. Cal destacar amb orgull que som una universitat de referència en l'àmbit de les ciències mèdiques i de la salut i que tenim la voluntat ferma de continuar fomentant la docència i la recerca en aquests àmbits. Òbviament, la qualitat del professorat, l'activitat investigadora dels departaments i instituts del campus, l'activitat investigadora i l'aliança amb els hospitals vinculats i els seus centres de recerca han estat elements determinants per oferir una docència permanentment actualitzada i una recerca de gran impacte. Però, sens dubte, per assolir aquest grau d'excel·lència i per projectar l'activitat de la Facultat de Medicina, també ha estat cabdal la col·laboració amb investigadors d'institucions internacionals de referència i la participació en xarxes i projectes internacionals. Com a rector de la UAB, vull posar en relleu que la doctora Lundberg representa un exemple per a tots nosaltres. No podem oblidar que el fet que la universitat sigui un entorn privilegiat per a la formació de futurs professionals i investigadors excel·lents s'explica en gran mesura per l'existència de persones excepcionals com la professora Lundberg, persones compromeses amb la tasca assistencial, docent i de recerca, i sobretot prou generoses per a compartir coneixements i esperonar-nos a complir la nostra labor diària amb honestitat, vocació de servei i entusiasme. La UAB, com a institució que té entre les seves missions fonamentals formar ciutadans socialment compromesos, l'exemple de la doctora Lumber ens és de gran valor. És, per tant, un honor acollir a la professora Ingrid Lumber al claustre de doctors de la Universitat Autònoma de Barcelona. Moltes gràcies. A la Universitat Autònoma no vestim ni gorra, ni birlers, ni res, però sí que acabem tots els actes de la manera més rigorosa que considerem més institucional. I això és acabar-la amb el nostre himne, que seria el cant del Gaudeamus Igitur, per lo que us demano tot que us poseu en peu per cantar-lo. Donem per conclòs l'acte i teniu tots a baix un petit refrigeri i moltíssimes gràcies per la vostra presència.